And then single stage, this is for the MCL. The gracilis was doubled. Only superficial MCL was made in this case. So one spike was here and the staple on the tibial side, almost around this 4-5 centimeter below the joint line and in the posterior part of tibia. And in the post-op period, considering the scarring of the posterior structure, I do applied external fixator here so that my knee will remain in reduced position. There will be no stress on the reconstructed ligament. So my usual plan is to external fixator for 3 weeks for chronic multi-ligament knee injury. But this patient came to me after 6 weeks only, in the fear that his knee may get dislocated again if I'll remove the external fixator early. So at this point, this was after the 6th week. So these two is for, this is for the posterolateral corner, the single things. This is for the MCL, the ACL and the PCL. And this, the MCL is in posterior half of the tibia. And yesterday there was discussion about the bump. I do use this posterior tibial bump with this, not with the gauge piece or so. This is the towel. And I haven't any this pressure sore or anything like that for last 10 years. We do at sports injury center also. We didn't encounter any pressure sore because of this posterior tibial support with the towel. And this is at the end of 6 weeks, around 10 degree of extension lag, and the movement is around 50 to 60 degree only. So if you are doing multi-ligament reconstruction in a single stage, this stiffness is one of the most common complications. Almost in 40% of the cases, you will have some degree of stiffness. So be ready for that. At the same time, you must counsel this to the patient that you may have loss of some range of motion. So ARS, please. So 2.5 months of now there is no further movement with physiotherapy. What we will do now?
2.5 months.
So orthoscopic ortholysis. This is the one thing you must say all your patient if you are doing all the ligament in single stage. That there is chances of 40% that you may develop stiffness, that we will have correct this with orthoscopic ortholysis only. So we did the same here. The mostly adhesion were in the suprapatellar area. And after this orthoscopic ortholysis, this much of the range we gain. And this is at the end of 5 months. Patient sent this video to me. And this is after 5.5 years. This is the recent X-ray. I asked, patient didn't return back to me after this orthoscopic ortholysis. He has started doing all his farming activity. You can see on the medial side, because of the medial meniscectomy, you can see there is arthritic changes is there. You can see the tunnel for posterolateral corner and MCL and ACL and the PCL thing. This is 5.5 year follow-up. And this was the clinical thing. Patient again sent this to me. So you can see it was done at the age of 50. Now he is 55 with all these multi-ligament reconstruction. He is jumping and he is doing all his farming activity.
Can I ask a question?
Yeah.
Excellent case. Actually, you got an excellent outcome. My question is related to your external fixator application after you had reconstructed all the ligaments. So I want to understand your thinking because you were managing that case clinically. So what was your thinking process? Why did you apply an external fixator after reconstructing all the ligaments? Was it there was a persistent posterior subluxation even after doing reconstruction, or probably that? Second part, the immediate after 6 weeks you have removed your external fixator. There was a flexion deform. It was not able to flex beyond around 30 to 40 degree. Do you believe that fixator was probably part of the problem because the femoral pins tend to adhere the quadriceps and cause fibrosis, and they limit the flexion.
So first question is that about the putting the external fixator. Since it was 6-week-old posterolateral dislocation, and there is invagination of the tissue from the medial side, but at the same time, because of the 6 week, your posterior soft tissue become very much contracted. So after dissection on the medial side, knee was getting reduced. You can see in the post-op intra-op picture also. But in the fear of there should not be any extra stress on reconstructed ligament, only to prevent that I put external fixator, in considering that the posterior structure may be very contracted, so there will be a stress on the reconstructed ligament.
It was stable
It was quite stable after reconstruction of the ligament. Okay. And usually I put external fixator only for 3 weeks. This patient came to me at the end of 6 weeks. I asked him to come at the 3 weeks, but he was in fear that his knee may get dislocated again back, so he came late at the end of 6 weeks only. And after removal of the fixator, there was no problem with that. There was no any quadriceps problem, and he started doing his physiotherapy, and the movement was reached till 10 degree to 60 degree. And after that, there was no further progression of the range of motion. So that's why I did orthoscopic ortholysis.
Okay.
Yeah, Arvind, very nice case. You removed everything from the medial side just to reduce the knee. That means you took out whole of the meniscus or what?
Yeah, medial meniscus root was avulsed, and it was completely came to the intercondylar area. At the same time, there is lot of retinaculum tissue, and the capsular tissue was also inside the knee joint. So in 2018, I was not very confident of doing the repair of this meniscus. At the same time, there was 4 ligament I have to do reconstruction also. So I took out the meniscus. And nowadays, I do the dissection between the meniscus and the capsule first, so that at least capsule and retinaculum part is out. Then I do reduction of this. I did 2 more cases similar like this. So I do reduction of the medial meniscus, then I do the repair.
Okay. So at that point of time, you did it like that?
Yeah, that time I did the removal of meniscus, capsule, and the retinaculum from the medial side.
Okay. So why arthroscopically? Why not opening on the medial side? Because anyway, you had planned for the MCL reconstruction. Then you could have repaired everything if it is salvageable meniscus.
So I did this, again I said it was the medial meniscus root tear also. So first I did this orthoscopic part, and then I thought let's take out everything from the medial side. That I did, as I said. But now I do everything with this orthoscopic method only. I usually don't open from the medial side until unless there is any chance of repair of the MCL.
So had it been the fresh scenario, would you have staged the procedure or all in one go? Because you can open the medial side, remove the tissue, repair the MCL, do an augment, and maybe collaterals at that moment and second stage ACL, PCL reconstruction.
So since considering the chronic case, it was not acute case. Most of the time in my practice, I do all the ligament in single stage from very beginning.
Even in the fresh scenarios?
Even in the fresh scenario also. Until unless there is no any bony component. If there is any small fracture, many a time I encounter that also. So for fixation of that with medial side or lateral side repair with external fixator, and after 4 week second stage surgery.
So very challenging case, well managed. You mentioned that you get 40% arthrofibrosis and you have to go for arthrolysis.
It is in the literature.
In 40%.
In my hand, it is 20% around. In out of 10, 20%, 10, 2% is treated by this orthoscopic ortholysis. But if you go in the literature, if you are doing all the 4 ligaments single stage, up to 40% patient will have some kind of knee restricted range of motion.
So that is, I get the term that it is up to 40%.
Yeah, up to 40%.
But not the median value is not, because 40% is way too high, way too high.
This is the one of the most common complication in single stage reconstruction of all the ligaments.
And how about your rehab program? What would you do for your multi-legs? What kind of brace, what kind of ROM exercise, where do you start and where do you finish? Anything about that?
So nowadays I have started range of motion exercises from day 1. with that posterior support in my CPM also, and when off CPM, then with the brace. Non-weight bearing for 6 weeks, and then the progressive range of motion. And my aim is to achieve full range of motion in between 6 to 8 weeks.
Okay.
Okay, last question on this case.
What time the arthrolysis was done from the index surgery?
Pardon?
How many months after the index surgery the arthrolysis was done?
2.5 months, after 2.5 months.
Okay.
After 1 month of removal of external fixator, there was no further increase in the movement for last 2 weeks. So if you do early orthoscopic ortholysis, chances of gaining full movement is high. If you wait for 6 months, 8 months, something like that, 9 months, then sometimes it's become difficult to gain full range of motion. So my threshold for doing this orthoscopic ortholysis for multi-leg stiff knees very low.
Thank you, Arvind. That was a very interesting case with
So,
a few take-homes.
I left a couple of slides, 1-2 slides.
Okay.
So this was about the range of motion exercises. Lot of literature say you can start range of motion from day 1. And take-home message about this, again, systemic approach is very important. Careful, orthoscopic, careful soft tissue dissection in chronic dislocated knee is very important. External fixator may play in role in early post-op period. And again, you have to be open about orthoscopic ortholysis. With all these, I am inviting you all for 7th Bihar Knee Orthoscopy and Osteotomy course. That has to be held at 12th May. Many of these have been there previously also. And already Rajiv Boss, Kanchan Boss, Sital Boss, all these have confirmed this. So please do come, and thank you.